Good evening. I'm psychiatrist Jay Fauver, live from Fort Wayne, Indiana. Welcome to Matters of the Mind. Now, in its 27th year, Matters of the Mind is a live call-in program where you have the chance to choose the topic for discussion. So if you have any questions concerning mental health issues, give me a call in the Fort Wayne area by dialing 969-2720, or if you're calling any place coast to coast, you may dial toll-free at 866-969-2720. Now, on a fairly regular basis, I am broadcasting live every Monday night from our spectacular PBS Fort Wayne studios, which lie in the shadows of the Purdue Fort Wayne campus. And if you'd like to contact me with an email question that I can answer on the air, you may write me via the internet at mattersofthemind, all one word, at WFWA.org. That's mattersofthemind at WFWA.org. And I'll start tonight's program with a question I recently received. It reads, Dear Dr. Fauver, is there a difference between addiction and self-medication for stress? I have a loved one who does not use alcohol regularly, but will often use it during stressful episodes in her life. That is always the million-dollar question when we hear about somebody using excessive amounts of substances of abuse, whether it's alcohol, marijuana, amphetamines, you name it. When people are using excessive medications inappropriately, or other than prescribed for that matter, we're always asking, okay, are you doing it because it makes you feel better when you do it? Now you might think, well, gee, that's why everybody gets high or they get drunk, they feel better. Not necessarily. Some people will use substances even though they don't want to. They know it's ridiculous to use them, but they feel like they need to. And when they need to, they will often take higher and higher amounts to get the same effect. If they don't use these substances, they feel worse, not because of their life stresses, they feel worse because they're not under the influence of the substances. So alcohol being a good example. Some people will drink only when they get under stress, they're anxious, they can't sleep. Many people get in trouble with alcohol because they can't sleep, and they use it as a means of giving them a sedative for nighttime relief with insomnia. So insomnia can be treated with alcohol very poorly, however, because it'll help you get to sleep, but then it gives you a terrible sleep efficiency thereafter. So if somebody's using a drug of abuse or alcohol or any prescription medication inappropriately, and they're using it for the purpose of self-medicating symptoms, we're always asking, okay, so how would you like to feel better if you didn't have that substance? How are you going to feel? What's it doing for you? So if somebody says they're using marijuana to calm their nerves, if you're using marijuana to help with depression, we're going to try to give them something for depression to overcome that. Same with alcohol. Many people will use alcohol not only for relief of insomnia, but also for anxiety. But many people feel happy when they drink alcohol. It's actually a bad sign if you notice when you're an adolescent or a young adult and you have your first drinks ever. If you have your first drinks ever and alcohol makes you feel really happy and on top of the world, that's a bad sign because it means that biologically alcohol for you is affecting this middle part of your brain called the nucleus accumbens, the pleasure center of the brain. And for you, it can cause you to crave it over the course of time for that joy and happiness. So if somebody's using alcohol, marijuana, any substance of abuse, we're always going to ask them, are you using it because you're trying to relieve some underlying symptoms that are problematic for you, or are you using it because it's gotten out of hand and now you have to use it to feel normal? Many substances, opiates for instance, alcohol, benzodiazepines like Xanax and Ativan and Valium, they will cause you to go into withdrawal if you stop them. So you have to keep using them. That's an addiction. You're often needing more and more. You're going into withdrawal when you stop them. That's an addiction. So the first thing we want to do for those folks is get them off the medication in a comfortable manner so that they can get their lives back. Otherwise, some people will use substances of abuse for the purpose of self-medicating symptoms. In those cases, we try to take care of those underlying symptoms. Thanks for your email. Let's go to our first caller. Hello, Ben. Welcome to Matters of the Mind. Well, Ben, you wanted to know if you miss a day of your sertraline, also known as Zoloft, do you double up on the dosage the next day or do you take your usual dosage? It really depends, Ben. Some people, if they miss a dosage of sertraline or Zoloft, they will start to feel zings and zaps in their hands and feet. They get this heavy feeling in their scalp, and they feel kind of irritable. And sometimes just taking the usual dosage the next day will not allow them to get over that kind of feeling. And sometimes they do double up. It really depends person to person, Ben. Some people need to double up on the dosage the next time. As a general rule, For all medications, we advise people to not double up if they miss a dosage, because if they double up, they're going to get more side effects with double the dosage on that day. So if you're taking a blood pressure medication, for instance, you probably don't want to double up on the dosage the next day if you missed a dosage, because you might get too low a blood pressure. Now, there are some medications where you can actually take it 2 or 3 times the usual dosage if you miss 2 or 3 days, one of them being levothyroxine, a thyroid medication. Levothyroxine stays in your system for 6 days. And some people will take it just a higher dosage every 3 or 4 days because they can't remember it, or that's how it's prescribed. So levothyroxine, or T4, it's also known as a thyroid medication, you can take it theoretically one big dosage about every 6 days. So there are some medications where you can stretch out the dosage like that, take higher amounts on some days, but for many of them, you want to take them day by day by day. Now, Ben, if you were taking an anxiety medication like I mentioned before, Xanax, Ativan, Valium, Klonopin, these kind of medications, you don't want to double up on those if you missed a prior dosage. You get way too sleepy by doubling up on them. Often your body will tell you that you missed a dosage with those kind of medications, because if you're taking them on a regular basis, you'll feel kind of anxious without it. Ben, thanks for your call. Let's go to our next caller. Hello, Elaine. Welcome to Matters of Mind. Elaine, you want to know if there's a diagnosis for people who talk constantly and monopolize a conversation and speak on hours, having a one-way conversation. Couple different things could be going on there, Elaine, and just speculating here. Some people will have attention deficit disorder. With ADD, or attention deficit hyperactivity disorder, some people will talk and talk and talk and talk, and they have so many things on their mind. They go from one topic to another, and it's a day-to-day phenomenon for them. Second scenario, Elaine, will be somebody who has bipolar mania, and during the manic state, they're not sleeping. They don't need to sleep. They're impulsive. They're overly socially intrusive, and they go from thought to thought to thought very, very fast and very quickly. And they just do this episodically when they're on the manic side. When they get depressed, they actually withdraw. So bipolar mania would be a possibility for people who talk and talk and talk. A third issue would be where somebody has what we call pedantic speech. These people have autism. When people have pedantic speech, they will often talk without picking up social cues that other people are not interested. And they will talk and talk and talk and go from one thing to another and almost have a conversation with themselves, so to speak, because they're not picking up social cues from other people. And then you have individuals who may have narcissistic personality disorder. These people are only thinking about their own needs, their own desires. If somebody brings up an issue about themselves, a person with narcissistic personality disorder will always bring it back to their issues. So there are various reasons why somebody may talk incessantly without picking up the social cues from other people that the other people might not be interested in what they're saying. Elaine, thanks for your call. Let's go to the next caller. Hello, Shelley. Welcome to Matters of the Mind. Shelley, you want to know if someone suffers from hallucinations, does that mean they have schizophrenia? Not necessarily, Shelley. When we think about hallucinations, basically hallucinations are a false perception. It can be a visual hallucination or an auditory hallucination. They can be a tactile hallucination. Those are the most common ones. Some people will have an olfactory hallucination where they're smelling things that other people cannot smell. So with all those things going on, basically it's a perceptual disturbance. The brain is misfiring and making you interpret things that aren't really there and other people aren't discovering themselves. So if you have a hallucination and it's going on day by day by day, especially auditory hallucinations where you're hearing voices, especially condemnatory of voices that are telling you really bad things, those can be indicative of schizophrenia, but not always. If it's going along with other symptoms, such as social withdrawal, difficulty processing information, problem with showing your emotional valence. I mean, these are all symptoms of schizophrenia. It's a big cluster, and it's going on for a long time, starting in men at the age of 16, starting in women at the average age of 24. So there's a cluster of symptoms we will identify with schizophrenia, hallucinations being one of them. However, people who have hallucinations can also have hallucinations under the influence of drugs of abuse. Alcohol can be an example there. If you stop drinking alcohol in 3 to 5 days, you can have what's called delirium tremens, where you are having difficulty with hallucinations, among other type of factors. You hear the old stories about people seeing pink elephants. Myself, I've never heard of anybody seeing pink elephants when they're going through alcohol withdrawal, but they will have visual hallucinations, and they'll have tactile hallucinations where they feel like there's bugs all over them. And some people going through amphetamine withdrawal will notice that too. It's a very uncomfortable situation. Not uncommonly, when somebody loses sleep, they can have hallucinations, visual hallucinations especially, once in a while auditory hallucinations, but if you're lacking sleep, it has some effects on the brains where you just don't process information adequately, and you can actually see things that aren't there, and you can hear things that aren't there. So that can be a factor. Once in a while, Shelley, we'll hear about somebody who has a severe depression, and with that severe depression, and only during the depressed time, they will hear voices telling them really bad things about themselves. And when you have auditory hallucinations, Shelley, basically it's because this little band of tissue going from the front part of the front part of the frontal lobe to the hearing part of the brain back here in the temporal lobe, it's called the arcuate fasciculus. The arcuate fasciculus lets the hearing part of your brain know that those are just your thoughts. So if you have thoughts and you think about something, you'll think about them often in words. Those words sometimes can turn into voices if this arcuate fasciculus is not working properly. So a problem with people who are having difficulty with hallucinations, especially auditory hallucinations, will be this arcuate fasciculus is impaired, and in doing so, the thoughts that are in your brain will turn into voices. And when they've done EEGs on these people, brainwave tests, they've actually identified that, yeah, the hearing part of the brain is firing up when people are having auditory hallucinations. So it's an interesting phenomenon, but you can have hallucinations for various reasons, schizophrenia being only one. Other reasons can be factors as well. Shelley, thanks for your call. Let's go to our next caller. Hello, Jonathan. Welcome to Matters of the Mind. Jonathan, you want to know, why is a person at greater risk of developing a mental illness if their parent or grandparent experienced trauma? It's hard to say, Jonathan, if your parent or grandparent experienced trauma, you can be at a greater risk for mental illness if that trauma related to the parent or grandparent caused the parent or grandparent to have mental disturbances themselves, and if those mental disturbances were conveyed to you as a child in various ways, such as emotional detachment from the parent or grandparent, or irritability, anger, emotional abuse from the parent or grandparent, that could put a greater risk for you to have that kind of trauma. So this is why emotional abuse, physical abuse, sexual abuse, it's often multi-generational because it will go down the generations. Part of that's genetic, but part of it is because if you've experienced abuse yourself, that's what you've learned, and that's how you will often interact with other people. People are instructed that they need to break that chain of abuse. If you've had a grandparent, a parent who was emotionally, sexually, or physically abusive, you need to block that chain, because often there's a cascade, multi-generational, of those kind of problems. So you'll hear about those kind of issues going on. If your parent, for instance, was a Vietnam veteran, or maybe a grandparent was in World War II even, yeah, they can have post-traumatic stress from those kind of experiences, and that can be passed on sometimes to the children. And as a child, up until the age of 8 years old, you're really, really vulnerable to any emotional, physical, or sexual abuse and the after effects of those. If you've had emotional abandonment or any kind of traumatic experience prior to the age of 8 years old especially, that can be devastating for you later on. It's not necessarily deterministic that you will have emotional problems if you had a tough childhood, but it certainly increased the probability. Jonathan, thanks for your call. Let's go to our next email question. Our next email question reads, Dear Dr. Pfeffer, what type of things should I prepare before my first appointment with a mental health caregiver? I do have a list of my medication, but what else should I have ready? We have at my clinic, for instance, questionnaires that go through all these different things that we want to know. And just to go through some of these things, you're on the right track there. What medications have you been on? What doses have you been on? How long were you taking them? And why did you go off of them? Or how do they do for you? Some people go off their medication because they felt a lot better. Great. We want to know that. So we want to know all the details about past medications. We want to know about your past childhood. Now, I'm not talking about some Freudian stuff here. I'm just talking about what traumatic type of things might have happened during your childhood? What kind of things were really bothersome for you? How do you think you got to where you are now? You know, if you have depression now, anxiety now, how did you get here? So we look at the past emotional type of things in your childhood. We often want to know what kind of coping strengths you have. Can you recall situations where you had really bad stuff happen to you and you got over it? And what kind of coping strengths did you have from that? I want to know, well, okay, the obvious questions: with whom do you live? Who are your main supports? I want to know about your pets and animals, because pets and animals can often be a good source of support. I'd like to know what are the main stresses you're going through right now, and what are your goals for treatment? People come to me with all the different goals for treatment, and I always ask them, what are your 3 main goals? How would you like to feel better overall? Because I might hear their story and look at their questionnaires, which we will provide for them. Then I'll ask them, what are your main 3 goals? And the 3 goals might be entirely different than I would have maybe thought. So I always want to know, what are your main 3 goals, and what are your main apprehensions about treatment in general? If we were to give you a medication, what kind of side effects do you really want to avoid? Now, we try to avoid all side effects, but are there any game changers where you would not take a medication if it did this, or this? We want to know about that right up front. It's very important, if you can obtain it, to know how your family members did if they were on any medication for your similar type of symptoms. So if you had family members who took medications for depression, and here you're coming to see us for depression, I want to know, were there any medications your family members took, how they did with them, what side effects did they have success, did they fail? I want to know as much detail about how the family members did on medications, because that's kind of an indirect means of looking at your genetics. We do genetic testing, and it helps to some degree, looking at how quickly you metabolize medications and what medications might have a good mechanism of action for you. But I think in many ways, it's very predictive if a family member did really well on a particular medication for the symptoms you're now experiencing. It's very predictive that you could do well with that as well, too. So we want to look at a lot of different type of factors out there. I want to know what kind of medical conditions you'd been experiencing, and how the medical conditions are not only affecting you emotionally, but what medications you're taking for those. So there's a lot of things you can get together before that first appointment, but I think you're on the right track. The first thing you need to do is get together your list of past medications, because the last thing we want to do is go round and round and keep giving you medications in which you've already failed. So we want to see if there's a pattern of medication treatment responses. So if you failed on 3 medications that mainly affect serotonin, well, we don't want to give you medication that's going to affect serotonin. We want to go a whole different direction. So that's why it's very important for us to get the medication treatment responses, as well as your family members' treatment responses as well. Thanks for your email. Let's go to our next caller. Hello, Marcia. Welcome to Matters of the Mind. Marcia, you want to know about medications, Trintellix and Trazodone. Trintellix is also known as Vortioxetine. It's been out for about 11 years now. You want to know about how they're used and what are their side effects. Trintellix and Trazodone are different medications. Trintellix has some ability to enhance serotonin. At 5 milligrams a day, it's going to enhance serotonin reuptake by about 55%. At 10 milligrams a day, it's going to increase serotonin reuptake inhibition by 65%. Then at 20 milligrams a day, it's going to give you about 85% reuptake inhibition. So the higher the dosages, the more of an SSRI effect you're going to get. SSRIs are the mechanisms by which we would refer to Prozac, Lexapro, Celexa, Zoloft, Paxil. These are the medications that are blocking the vacuuming of serotonin back in the firing neuron, and in doing so, they allow serotonin to bounce around in the periphery for a longer period of time. Trintellix has that effect, but there are 14 different serotonin receptors. So if you think about the serotonin presynaptic or firing neuron as being like a shotgun, it's firing out these little serotonin bullets, all right? So number one, with an SSRI effect, a serotonin reuptake effect, you're blocking the vacuuming of the bullets coming back in the firing neuron. But secondly, those little bullets are rolling out there and they're stimulating 14 different types of serotonin receptors, which all do different things. In the case of Trintellix, you're affecting 5 of those 14 receptors very specifically and directly, and in doing so, you're enhancing serotonin, but indirectly affecting dopamine, norepinephrine, glutamate, and even GABA. So there's a lot of different chemical effects you're getting out there with Trintellix. So it's an antidepressant medication that, yeah, it affects serotonin to some degree, but it specifically will improve the speed of processing of information. So it helps the processing speed in your brain, similar to increasing the increasing the broadband speed of your internet. So you want to increase the speed of your internet. That's what's happening with Trintellix from an antidepressant standpoint. It's improving the processing speed of your brain. So that's Trintellix. Biggest side effect of Trintellix can be some nausea. The nausea occurs over the first couple weeks or so. Typically, you take it with food. It's often lessened, especially at a lower dosage. Trazodone is a whole different medication. Trazodone will specifically and selectively at doses up to 200 milligrams at bedtime mainly affect serotonin 1A and serotonin 2A receptors, and in doing so can give you a good quality of sleep. In other words, it'll help you get to sleep within about 30 minutes, lasts for about 8 hours, and actually will increase the depth of sleep. It might give some people strange dreams because it will allow some people to dream more, but it's a medication that was originally Food and Drug Administration approved back in 1995, I think it was. And in 1995, FDA approved for depression. But we found that for depression, you needed doses of 300 to 600 milligrams a day. Trazodone was not FDA approved for sleep, but that's how we've been using it for the past 25, 30 years now. For sleep, you use doses between 25 up to 200 milligrams at bedtime. Just at bedtime. Biggest side effect of Trazodone that people will find annoying will be about 1 out of 19 people will get a stuffy nose. So about 1 out of 19 people will get a stuffy nose. There used to be concern that men would get painful, prolonged erections with Trazodone, but that occurs in about 1 out of 5,000 cases, maybe 1 out of 7,000 cases by some reports, but it's related to the doses on the higher end. We don't use those kind of doses for sleep, so we rarely hear about that, Marcia. So Trintellix is used for depression, Trazodone is used for sleep. A common combination will be used in that manner because Trintellix might not help you with sleep initially, and maybe never, but Trazodone can be used as needed just for sleep. It's considered to be off-label use, but it's been used extensively for over 30 years now. Marcia, thanks for your call. Let's go to our next caller. Hello, Jane. Welcome to Matters of the Mind. Well, Jane, you'd mentioned you take levothyroxine for your thyroid. I mentioned that earlier. But you wonder if it's also an antipsychotic medication. Will that affect you, and why does a medication have multiple uses? Levothyroxine, Jane, is not an antipsychotic medication. Levothyroxine will increase thyroid levels naturally. Now, you can take your thyroid out. You can have it surgically removed because of thyroid cancer, and you can replace all your thyroid with an oral medication. The tricky thing about levothyroxine, T4, is also known as the name of it, T4, stays in the system for days, and it breaks down into T3. So T3 is allothyronine, and T3 is something that's very short-acting, very energizing, and it's been used for years as an augmentation agent for depression. So T4 breaks down to T3. T4 stays around for a long time. Now, if somebody has difficulty with fatigue, depression, they can't concentrate, we're always going to check the thyroid level. If your thyroid level is low, you can take levothyroxine and help with that. But generally, levothyroxine is a medication that is something that is taken on an empty stomach. You got to take it either an hour before you eat or at least 2 hours after you eat or have any beverages. It can't be used with coffee. Coffee inhibits its absorption, so you have to take it on a totally empty stomach. And for many people on levothyroxine, for instance, we'll have them take it at bedtime. Just keep it at bedside, and if you happen to wake up in the middle of the night or before you go to bed, if you haven't eaten for a couple hours, yeah, that's when you want to take it. Thanks for your call. Let's go to our next caller. Hello, Laura. Welcome to Matters of the Mind. Laura, you recently found out that you dated someone who had paranoid schizophrenia and stopped taking their medication. What are the warning signs that should be evaluated before things escalate? When people have schizophrenia and they stop their medication, Laura, it's kind of like somebody with epilepsy who stops their medications for seizures. Over the course of time, it's very likely those seizures will resume. With paranoid schizophrenia, the first thing you'll often notice when somebody's having trouble will be they get a little bit more anxious and they start to lose some sleep. Once in a while, they'll indeed hear about voices talking to them or having some really bad thoughts. We call them fixed false beliefs, also known as delusions. Delusions are fixed false beliefs where they start having some beliefs about other people or things that they see in their environment that don't make a lot of sense to you, but they insist that they are true. That's why they're called fixed false beliefs. Those are indeed delusions, and that's a symptom of schizophrenia, but often early on, we'll hear about people having difficulty with sleep and having more anxiety. And that's where I'll often be able to encourage somebody to take their medication, Laura, because even somebody with poor insight into their illness of schizophrenia, and part of schizophrenia, part of the manifestation of that is that they have poor insight. They don't know they have an illness. That's part of the illness itself. But they do realize that a lot of anxiety and feeling uncomfortable in social situations and not sleeping are reasons to take a medication. So sometimes we get people back on their medications with schizophrenia because they don't like to feel anxious and they don't like to have a lack of sleep. Lack of sleep makes everybody feel lousy, and they realize that. So we try to get them back on the medication on that basis with the intention in the long run to help with the ability to process thoughts and be able to feel more emotionally engaged. Now, Laura, fortunately nowadays we have a lot of long-acting antipsychotic medications that last for weeks, if not months. So you give somebody an antipsychotic medication, a long-acting formulation, it stays in their system for a long time. That's nice for somebody who has an illness where they don't realize they have an illness. Laura, thanks for your call. Unfortunately, I'm out of time for this evening. If you have any questions concerning mental health issues, you can email me here at PBS Fort Wayne by emailing me at mattersofthemind, all one word, at WFWA.org. I'm psychiatrist Jay Fauvre, and you've been watching Matters of the Mind now on YouTube. God willing and PBS willing, I'll be back again next week. Thanks for watching. Good night.
The preceding program on PBS Fort Wayne was made possible in part by
Cameron Psychiatry, providing counseling and care for those that may struggle with emotional and behavioral challenges. More information available at CameronMCH.com.